Good afternoon and welcome to healthsystemCIO.com's All-Stars panel, Application Transition, Legacy System Retirement, and Data Archival, a webinar tweet chat combo from healthsystemCIO.com, sponsored by Galen Healthcare Solutions. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemCIO.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our managing editor and director of social media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can view it in the media viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel and the polling panel today. The Q&A panel is for you to send in any questions as they occur to you. We'll take those later in the program. And the polling panel is going to open up when we have an audience poll today. We're actually going to do 2 quick polls, and then we'll take a look at the results. And you can download the deck by using the URL on your screen. It's been sent out in the chat box, and it's also at the bottom of our slides. Just so you see how we're going to spend our time today, first we're going to go about 35 minutes with our featured panel presentation. And we've got Douglas Miller, Project Director with Partners Healthcare, April Morris, Program Manager with Catholic Health Initiatives, and Christy Erickson, Director of Clinical Transformation Services with Galen Healthcare Solutions. So without further delay, we're going to jump right into our discussion. Doug, why don't you kick us off? Can you give us an overview of your role and organization?
Sure thing. Thanks, Anthony. So my name is Doug Miller, and the past 2 years I spent as a project director under Partners Healthcare. Partners has been around since '94 and was started by Brigham and Women's and Massachusetts General Hospital, and includes several other specialty hospitals, managed care organizations, community health centers, etc. And my role specifically was geared towards focusing on archiving strategies for data by systems that would be sunsetted due to the rollout of Epic across the Partners portfolio.
Very good. April?
Hi, I am April Morris. I am the Program Manager of Application Strategy and Lifecycle for CHI. We are a values-driven organization. We are also one of the largest nonprofit health systems in Englewood, Colorado. We operate in 18 states and have 101 hospitals. I'm responsible for strategy as well as implementation of our national archiving program. To date, we have archived 31 systems, which includes clinical and non-clinical archives. This has resulted in a reduction of operational cost by millions.
Very good. Very good. Christy?
Thanks, Anthony. It's great to be here today and to join my esteemed panelists, April and Doug. Galen, a little bit just briefly on us. We were founded in 2005. And we comprise of technical, professional, and product teams. We've been doing legacy system retirement for 5 or 6 years now, with over hundreds of migrations from all types of systems. Our focus is on clinical and revenue cycle systems, and it sort of separates us from others in that we absolutely know healthcare. Part of the key factors is we provide the full suite, everything from legacy support of a system as you're getting ready to migrate over, to upgrades of those systems, to the actual archiving, extracting that data out. We really use our own teams. We don't rely on any third party. The caveat would be if you were hosted, and do the extraction with our own proprietary archival ETL that we built to make this a streamlined, efficient process, all the way to the support. Once the system's live in the archival, we absolutely take care of it from the cloud, keeping it up to date, and take all of that retirement away. And for those that are staying around, we certainly have optimization for EMRs and integration points that were used in our PS and TS. I participated in both of the early on projects for both of our panelists today, for partners in CHI, and today I really own process improvement of the archival solution, from all the way from the sales to our implementation teams, even to the support process.
All right, very good. Thank you, Christy. All right, April, let's start with you. What were the key drivers for EHR transition, and what were the key drivers for data archival?
Sure, thanks. So I really want to share the results from our lessons learned and best practice. And CHI identified an opportunity early that really drove our decision to archive. So through acquisitions and upgrades, we have 600 plus applications across our enterprise that were ready for retirement. And of course, this number continues to grow. The reality is significant ongoing operational costs for applications and infrastructure of these legacy applications. There's also an increasing lack of knowledge to support these legacy systems because resources transition to other priorities or they move on. We also were facing risk of incompliance, duplication, data loss, as well as financial exposure. So although the core functionality is no longer needed, there are legal retention requirements to keep the data. So in 2015, our organization strategy was to implement a national clinical archiving solution, and we were looking for a partner as well as a product that guaranteed no data left behind. We were also wanting a product that ensured the integrity of our data through the extraction, transformation, and load process. CHI also has very complex compliance requirements, and we needed a solution that could align to those requirements. Sustainable cost. We wanted to spend $1 and save $2. The act of archiving, if done correctly, can fund itself based on the amount of savings achieved. And also, it was very important for CHI to have scalability. So CHI has a spectrum of applications from clinical to revenue to payroll, timekeeping, et cetera. So we really needed a partner and a product that provided that depth and width of clinical specialty.
Okay, very good, very good. Doug, your key drivers.
So for us, our key drivers were the fact that the partners was mandating the transition to Epic as our core EHR. So specifically at the Cooley Dickinson Hospital, where I spent the past year on this project, we needed to account for all of the data in 3 EHRs that were going to be retired, along with another dozen or 2 ancillary systems that had to be retired. So we needed to archive or come up with a strategy, not just to archive all the data in those products, but we also needed to have a product that could provide access to that patient data, some of that patient data at Epic Go Live, so that our providers could have access to patient histories and other data that affected their patient care.
Let's talk a little bit about this concept, April, that you mentioned of no data left behind. Is that always the case, or sometimes are you selecting that you do want to leave some data behind?
Great question. So when we select an application for archive, one of our first goals is to really put that application through archive criteria, which means we want to make sure that that application needs to be archived and what its legal retention requirements are, and specifically what data from that application we need to expose back to the end users primarily to be able to react to legal medical requests. And as a process, we do take all data and we ingest that data. but we are very specific about what we expose back to the end users.
I like that term, what we expose back to the end users. Tell me a little bit more about making that decision process. How do you determine, do you have committees where the end users will be involved in determining as a unit what they need to see? You can't just say as one person, right? Because they'll say, well, we're going to see everything. Well, no, maybe not. So is there a process by which you determine what you want to expose to the end users?
Absolutely. So one of our very important lessons learned was to bring compliance, legal, and HIM to the table at the beginning.
Mm-hmm.
They are your advocate, your navigator, as well as your governance. It's really important to remember that IT provides the mechanism to transform and retain the data, but it's not the owner of that data. So we partner very closely for 3 years in the program with our national compliance, HIM, and legal teams to make sure we have clearly defined requirements for what we keep, how we expose it for legal medical requests. We also partner very closely with our markets. So we go into our markets and we have a very specific set of requirements of what we deliver in a product, but we also try to work with our local HIM leadership in those markets to make sure that we are aligned on those requirements and, just make sure that we're not missing a piece of information that's really important to expose.
Very good. Doug, you want to weigh in on some of that?
Sure. Yeah, I just one other thing to add to that in the discussion about what data to keep and what to expose, so we did involve all the key players or stakeholders when evaluating each application for what was going to be kept and what was going to be accessible for clinicians and other disciplines during the transition to the archive. So certainly from almost the beginning of the process, as we were selecting a partner to work with, we involved clinicians and others to help us evaluate not just the tools, but the background of the vendors that we were selecting from, and all the way through the process of the data migration and the setup of the systems and configurations, all the way through into final testing. So it was very important for us to involve all the consumers of that data, including HIM. And since we were in a little bit of a different situation where we were actually going live with essentially a data viewer sitting alongside of our Epic implementation, we thought it was really important that our clinicians were able to hit the ground running with something that not only they had seen before, but something they had invested time and effort into helping us implement.
Doug, let me ask you, is there a couple ways to think of this data archiving? Some data people don't need, or at least you think, you go through a process of deciding what the end users are going to need from an archive, from a system that's being archived going forward. You make that decision based on some sort of governance process, what you're going to expose back to the end user. Do you always, and do you at some point get rid of everything else, or do you always kind of keep it in case somebody requests a data element that they didn't seem to need when you did the first process of deciding what to keep?
Well, so in my experience, I don't think you're going to get anybody to commit to deleting or getting rid of much data. So one of the reasons that we've selected the Galen Vital Center product was that they were taking a snapshot of the databases that we were retiring, and although we were presenting, a certain amount of information to be consumed by end users, the whole database does sit in long-term storage. So if we ever decide that there is an element or other data that we're looking to see or present, or we want to make a change that wasn't part of the initial evaluation and delivery, we can go back and have them pull that data and configure the system to display it in the manner that we see fit. So it's nice to have that as an insurance, and going forward, especially when you're selecting a product that you're going to be with for 10, 20, 30 years down the road, that you've always kind of got that in your back pocket if you need it.
Right. Do you agree, April? Is nothing really ever deleted?
I do agree with Doug that
it's even scary to talk about it, right?
Right.
Well, I want to clarify that some things may get deleted, but getting someone to actually say a right to delete something, I guess that's the piece I was alluding to.
Go ahead, April.
Yeah, it really depends on who you're talking to. So if you're speaking to a clinician, they want their data forever. Or if you're speaking to a patient, they want their data forever. However, if you're speaking to compliance, risk, and security, there are time limits on how long we keep that data. Otherwise, it creates risk for the organization.
Right.
Yeah,
right.
So, it's
so
really
there's negatives. There's negatives in terms of cost and risk for keeping things longer than are necessary.
Absolutely, and it's really important for our organization to adapt to record destruction and purge, because that really does reduce the ongoing operational costs to retain that information.
I think that's a great point. That's a great point and a great issue. So I'm glad we touched on it. Doug, let me go back with you over here, and if we've covered things, just say, we already covered it, but was Archival pursued for maintaining legal, medical record, clinical continuity, or both, and why?
So at the Cooley Dickinson Hospital, it was for both. So with the Partners Healthcare mandate to move to Epic, we were not really allowed to bring much data from our legacy systems over. We could bring immunizations, allergies, problems, some other parts of the patient records, but really that's about it. So in terms of patient history, we didn't just need to archive that data, but we also needed a solution that would allow clinicians to view patient data in a manner that didn't negatively impact the level of care as they were delivering it. So essentially a data viewer. And that data viewer needed to be launched alongside Epic at Go Live. So, with competing resources on such a large project, you can imagine the complexity of trying to deliver that. But we also needed to provide HIM the ability to act on ROIs and things like that. So one option, obviously, is to keep the legacy systems around in a read-only state, but obviously that could be very, very costly over time. So our focus was really on finding a solution that was not just an archive, but also something that can function, not necessarily replicating the legacy systems, but getting close enough to be functional and delivering value to our clinicians and other providers as we stood up Epic and this other solution alongside it.
Very good. April?
So do we use the archive for clinical continuity as well as the ability to react to legal medical requests? For CHI as an organization, we really needed to spend some time as an organization to understand our purpose as well as our model for archiving. And so the product that we use can be used for clinical care continuity as well as academic research or, specifically to react to those legal medical requests. We really wanted to design our model to be repeatable. We refer to that as out of the box. So although each legacy application can be unique in its own way, it's really important to limit that scope so that we can gain that velocity and value for our organization. Also, another consideration is, depending on if you select to use archive for, clinical continuity versus limited to responding to legal medical requests, that could impact other areas of your implementation, your training model, your validation model, and also how you deploy and support your archive. So for CHI, our choice was to limit our model and open it only to our HIM end users.
Very good, very good. All right, April, let's stick with you on the next question. What evaluation criteria did you use when selecting a vendor?
We started with request for information. We were very specific in our requirements. Out of the gate, we were green in archiving, and so we worked with our clinical requirements from compliance and HIM, and we developed an extensive and complex list of requirements for clinical archiving. So it was really important for us to have a partner with that extensive healthcare knowledge, someone that could offer best practice in the industry. Also, what was important to CHI was that ability to react to legal requirements today and in the future. So meaning a partner that submerges itself in healthcare legislation and is proactive with their product research and development. They can see what's upcoming from a legal perspective, and they prepare their product to adapt to that.
Yeah, and I guess, April, you want to have confidence that somebody's going to be around for a while as much as you can, right? I mean, talking about archiving issues, that's long-term stuff. So you want to make sure a vendor's solid. Would you say that's the case? I mean, that's part of the consideration?
I would 100% agree with that, Anthony, and it's a bit scary to think about if we were to go through this process and have so much data in an archive and have to face one day basically redesign of that data and another product. Right.
Very good. Doug, evaluation criteria when you were selecting your vendor?
Sure. So ours was a little more immediate, as we had the aforementioned go-live date with Epic kind of staring us down in November. So the criteria, the base criteria we were using is we were looking for a scalable solution, since we needed to immediately move 3 or 4 applications data into a solution, but we wanted to build that out over time into a couple of dozen legacy data applications. And some of the other criteria that we used on functionality, we needed something that had things like single sign-on functionality, the ability, a vendor that had the ability or experience integrating with Epic, and the solution needed to launch in the context of the patient being viewed in Epic, so that it was quick and easy for clinicians to use in our use case. As I mentioned, that we did need something that could handle all different types of data with a singular user interface to make it easy to use for our users.
Doug, I want to throw audience question at you now. I think it's a good time. Did you try to expose the data to the end user within the new EHR, which would be Epic, or in a separate system? You used the term data viewer, so I wasn't quite certain whether that's in Epic or a separate system, but that's an audience question.
Sure. So with our application, we were able to have partners integrate the Vital Center Online product right into Epic. So as a user is in Epic viewing a patient, that user can click on a link that opens up the Vital Center Online tool within the Epic session. And one of the requirements was for data security was that Epic would maintain control of the Vital Center Online session. So if the user happened to close out of their Epic session, it would close out any patient data related to the Vital Center Online system as well. So once they're in Epic viewing a patient, clicking on the VCO link would bring up the viewer within Epic, and they would be able to not only navigate across the EHR data that they're looking for, but any system that they have access to in the archive, they would be able to look up patient data related to that patient in context at that moment.
Very good. April, does this question apply to your project?
We have the ability to integrate and connect to Epic from our archive solution. And we are considering that in our long-term planning. So if we were to decide to encourage that clinical access, this would become a priority. But today, this is, we have a lot of other initiatives going on that, that take priority.
Okay, very good. All right, we're going to throw our first poll question out there, and you should see it open up now. How does your organization approach sunsetting of legacy applications? And this is a select all that apply. Maintain legacy system and dependencies, raw data, backup and database, healthcare-specific archival solution, industry-agnostic archival solution, need for archival but haven't started. So if you could answer that, we would appreciate it. We'll take a look at the results in a few minutes, but go ahead and answer that poll, and we will move on. Christy, let's go to you. And if you want to address these projects, that would be great. How much data was archived and what types of data?
Yep, so both had significant amounts of data. There were 3 systems for partners. I'll start with them. They had an acute care system and then 2 ambulatory systems that were archived, so they were all clinical systems. And then one of those systems also had some revenue cycle data. And then for Catholic Health Initiatives, they've had several systems. They've had both revenue cycle systems as well as clinical systems. Likewise, they had an acute inpatient system, and then the majority and the bulk of them have been ambulatory systems to date that they've archived.
April, anything you want to add to that?
No, I echo what Christy said. We have been very successful in our implementation with both our acute model archiving as well as our ambulatory. And I think we have great synergy with our partner. So once we go live with our product, to date, we have not found any issues after deployment.
Very good. Doug, any further color on Christy's answer?
I would just add that after the initial 3 systems that were archived, that we've got another 15, 16 systems. We're working in phases, so phase 2 is currently underway. And so the long-term project is probably going to stretch out over a year, but that was by design.
All right, very good. Let's take a look at the poll results here. And Christy, you want to take a look at these results and tell me if you've got any thoughts about them. 45% for the first answer, 39, 39, 16, and 32. So 16 is our low one, industry agnostic archival solution, and our high one is 45% for the first answer. Do you see the results there, Christy?
I do, and I think it's quite interesting, as April, I think, alluded to, and both Doug has touched on this as well, you know, looking at what you need to archive and when, if we really step back and think about it, and knowing when the first electronic health records came up, and certainly with all the mergers and acquisitions that people are having and obtaining new practice sites, sometimes they probably never ever implemented that system. I think organizations are really looking at the cost that are associated with maintaining those legacy systems. As April alluded to, every state, there's federal guidelines, but every state may have their own criteria of how long do you need to keep for a mother and the baby, until what time does the child grow up, how long do you have to just keep the records on for any request, whether it's a regulatory request, whether it's insurance request, whether it's patient request, as people hop and skip insurance plans and request for their records. So I think organizations are beginning to look and really strategically looking, what do I pay for licenses fees? How long is that? Some healthcare vendors have certainly got on board with this, and if they didn't have read-only systems, they've either baked that in, they certainly charge for that. And if you look at that cost versus sunsetting and knowing what to sunset and how to access it. So from a clinical background, I totally appreciate, I want to see all the data. I want everything that could be possible to be had because that patient, I only have so much time to be able to see them. And knowing really what to archive and put into the system and looking at that, how long will you keep some of these legacies? I think it's interesting that not quite half, but a good portion are still maintaining those legacy systems. And we're certainly, I mean, here's two great panelists with a lot of systems. I mean, some of these larger healthcare organizations can have upwards of 50 to 100 applications that they're, you know, servicing and maintaining. Some can be cloud-based, some can be on-premise, the servers that they're holding. But, you know, if I get a little teeny baby practice and I get a big practice, you know, that's a lot for any healthcare IT department to sort of manage and keep up to date, not to mention the cost.
Very good, very good. Thank you. All right, April, we're going to go to you on this one. What are the risks involved with maintaining a legacy application, such as lack of upgrade, support, compliance?
Sure. So there are certainly a lot of risk when it comes to maintaining that legacy application. First, compliance and security. So with outdated application support, lack of upgrades to hardware as well as the supporting software for the servers, hardware refreshes. Depending on your organization, it could be, you know, you could have a 6 to 8 year cycle to refresh the hardware. It also exposes that security vulnerabilities if you do not maintain the support and upgrades, which of course leads into those legal risks. Another risk of maintaining that legacy system is the cost for the legacy application as well as the infrastructure. It's definitely significant in an organization our size. Another risk is lack of tribal knowledge. So with organizational turnover, adjusting priorities, there's a tendency to lose your SMEs for that legacy application. And then also, CHI has experienced this personally, is data loss due to corruption or hardware failure. So we had an experience with a very high priority legacy revenue system that as we were starting the archive project, it crashed at the start of that project and all the data was lost. So we just are dealing with a lot of those outdated and ancient type of systems.
Very good, very good. Christy?
Yeah, I mean, this is just what the cost that I just talked about, right? As April's found, and we've certainly seen this on the flip side on the implementation, right? That what April just said is the tribal knowledge loss. I mean, it's not just the cost, right, of the hardware. You know, if you're running SQL and your vendor says, oh, you'll upgrade, but you've got to upgrade your server. It's not just that and having those people maintain that application, but the costs are associated and the time spent for someone needs to get into the system. But the practice, maybe it was a medium-sized practice, but they've all left, and who gets in there? Again, sometimes these department of ITs are getting these systems that they're inheriting, right? They don't know it like the back of their hand because they didn't implement it. Maybe it was from an acquisition. And so I think the cost, and when you put it on paper of, okay, well, how do I get that information out? How do I learn that? How do I cross that over now into my archival? And do I really know what that data looks like if the bulk of the people may or may not be in that practice? Or better yet, you're asking some of the clinical SMEs or the revenue SMEs to help you in getting that data out. And that's all part of cost of just maintaining, and, you know, when they can't get into their system today, and now we move that over to archival, that can certainly be a perk to sort of in your timelines of how you can make that happen.
Very good. Let's stick with you on this question, Christy. What does a typical implementation timeline look like, and what are the different components of a project?
Yeah, great question. So our timelines can vary. It's certainly going to depend on the system being archived, and we've talked about the client, right? There could be processes, governance, you know, change control that impact that. On average, our projects run from 3 to 6 months. I'd say most fall within the 4 to 4.5 month time frame. And our team will, we certainly look and adapt our project plans based on the system that's being archived or the processes that are going to be in there. I do want to point out, it's important to note that when I'm quoting our average is 4 to 4.5 months, we are, this is from start to finish, from the time you get introduced to the team to the time of support. So, typically there's no surprises here. It's not like we're going to go to a third party and ask them to go find the data in that database, extract it out for us. The caveat would be is when we have, if it's a cloud-based, but we're asking for the files to come over or we're asking for a copy of the database. We're not reliant on somebody else. So on average, and certainly for the two panelists on both of their projects have run in that 4.5 time frame. The different components, standard in IT world on how a project starts. So we have 5 phases. First one's initiation. Most of you can probably think what that's like. It's really getting your kickoff team from Galen that will include a project manager, implementation consultant, and a technical consultant. And then establishing access. As we just mentioned, some of these systems, no one's really been in them for, it can be a year, it can be 4 years, it can be 6 years. So finding out who's got the keys to the kingdom, who has to set up the team, we define that at a certain timeline, but it can be challenging to get that out. So our first phase is initiation, where we're really just getting the access. And then the bulk of the project really falls into the staging. That's us discovering the data. Our technical team has seen as I mentioned, over hundreds of migrations that we've done, different databases of all different types and styles, finding out where that data resides. Back to that point of no data left behind, and they're then extracting that data out. They're spending the time to find the right sample size for your testing process. And so that is really the staging phase, which is looks mostly behind the scenes with our technical folks. And then we move to the testing. This is where clients really dig in. Our team will do an initial smoke test. We will also do an initial data integrity. So we'll be looking in your old system, whatever the source system that you're moving from. We'll look at a subset of patients early, try to identify any issues and have them resolved before we engage the client into testing. And then the client team will come in and test. That testing, you can imagine as I'm painting this picture, if I just left the system 6 months ago, there's a lot of people that know the system, a lot of people that might even remember the data and where to go. The older you get back in your archival, we find that, it's certain people that never remember how to get in, or certain people know where it is. But I can't tell you the value of knowing that data and owning that data and making sure that it really is no data is left behind. Not only do we provide that to you from a technical level, but you see it in your own eyes when you're looking at patients in your source system. And so the testing will include a smoke test, data integrity, and user acceptance. I think both of our panelists today have mentioned this. Having HIM involved, many of these archival systems, if there's one thing that they will all do, that will be release of information. So having them on board early, making sure that they have user acceptance of not only the product, but understand that product, they become SMEs for the rest of the HIM department. Pairing up a clinical person or a revenue cycle person with an analyst, so as a physician, as a nurse, these folks probably don't know the speakeasy of, if you will, of the IT testing world, but the analyst, the IT team certainly does. So oftentimes we see when we're pairing them up together, they can quickly identify the issue and then understand should it or should not be there, working alongside with our implementation and technical consultants. And then the last 2 phases are the prepping, right? Go live planning, mostly that is us extracting out the data for the final into the production archival solution. So each client has a staging archival solution and a production archival solution. And then at the same time, we're educating the end users. Or your end users have to, it's very intuitive to get into the system. Do they have to navigate? I think Doug pointed out it was a single sign-on that they use. Do you have to teach them what button to click to be able to see this data versus do I have to teach them the URL or the icon that they have to go click to get into the system? And then lastly, go live. It seems like a quiet event compared to what you say go live and you say epic. I think people think big. You know, it's if they use it just for archival, sometimes they're sort of quiet. They're not like these huge things. There's a few questions come in. Other times, like partners, you know, these people went on to a new system at the same time learning archival at the same time and having to find their stuff. And during the go-live process, there's a formal transition to our support team for ongoing maintenance. And then that's usually when we're negotiating and finding out from the client, when do you really decommission that server? Who's the last user who will be in? Because we'll pull the final audit records from that source system, and that's the last step in the process that happens typically after go-live, when they've locked it down for everyone and no one can get in and view anything.
Christy, I have a couple of questions for you sort of on this topic. You mentioned whether the health system has the data, meaning it's on site, or it might be in a vendor cloud. Or we're getting more into that now as opposed to a few years ago, but you could still certainly run into customers that have their data in a vendor cloud. I would imagine that sometimes that might make it easier for you as opposed to trying to find someone who's been with the health system 30 years and has some idea of what the password might be. Or it might be more difficult, and I don't know to what degree different vendors are easy to work with in terms of you approach them and you say, hey, we need this customer's data. Some are easy, some are not. Sometimes working with the health system is easy or not, depending how old it is. So that's sort of question one. And then question two is, have you had health systems come to you with deadlines that are unrealistic, meaning I need this done in a month? And you say, well, that's just impossible based on what you want. So do you have a message to potential customers who might be looking at data migration projects about, hey, this is what you need to do? And, you know, you did mention the potential timelines, but take all that and run with it.
Yeah, so let's talk about the vendor ease, and are some easier than others? Well, as in life, there's always something harder and something easier. That's the answer to your question.
Very good.
I think the technical side of my house, and you know, I only skirt on that pond a little bit, would say sometimes it's harder for the vendor. So to be clear, obviously the client's asking for the data. It's their data to ask for it, so we don't necessarily get in. At most, we'll tell them the type of file that we want, whether they're taking a full copy of the database and restoring it somewhere for us, or they're giving us flat files. So we walk the client through that. And I think that's the one thing that you have to consider that in your timeline, right? If the vendor doesn't have a sense of urgency like you might have, that you can't control, right? The client's got to push that vendor. But 9 times out of 10, you know, we have a plethora of both. The on-premise, I would probably say that our technical team would say that's easier. Once we have access to their skill set to get in these databases and find what they need, it's way easier than having to work independent. If, you know, we're at the mercy that they gave us the files, right? That data, no data behind, we have to continue to look for stuff to make sure we've gotten everything. So the challenge of getting it and then the work, I think it's one and the same. Deadlines. Oh, great question. I think the one thing is the strategy. We certainly have clients that, you know, partners did it and were able to, not that they weren't resource constrained, and Doug might talk about that. When you're doing a cutover, and if you think about it, you're asking them to not only do a migration, or let's just take Epic as a big thing, you know, their whole team's getting educated, many of them are big bangs. You're asking that user to adopt a new EMR, but if you're tagging on VCO, Vital Center Online at the same time, it can be challenging to clinical staff. You know, I don't know that I can sort of talk about the revenue because most of that, they're just doing release of information. But if I'm using that as a continuity of care, you know, you don't want to slow up the stream of the flow of the clinic that much. So I think looking at those deadlines and what is the capacity? What's your competing projects? You know, Archival both April and Doug have, I think Doug alluded to there's 15 or 18. You know, these aren't, they've got phases, right? They've got multiple projects. Both are running anywhere from 5 to 8 projects right now in staggered event. Well, you've got to have people for that, right? Not just the testing, setting up the access. It's really about looking at that competitive. We've had clients that say, look, this is when my contract ends. I don't want to extend my contract. My vendor will only let me do a 5-term contract. And that's when you really need strategy, and we've helped clients out, not only just with data governance, but how do you strategize? Have you got a master sheet with every application you own? What's its length of term for its contract? What's the amount of the contract? How easy is the vendor? Can I go and try to do a buyout? Can I extend for this much? Do I not have to extend? We certainly have, on our side, we've certainly worked with clients to meet timelines, but certainly if you said I need it in 30 days, well, that's not physical possible, right? And rightfully so, we should be saying no, because you don't want to cut corners, right? This is the legal medical record. So there's efficiencies that can be gained, and you can certainly throw more people, right? More people and more money sometimes gets it, but not always, right? There's still you want to do the due diligence. But I would say for those that are looking at deadlines, if you know you're going to archive, or if you've never done this exercise to figure out all your contracting, because of all the migrations experience we've had in helping people from legacy support all the way to the archival, we've certainly helped people strategize to pick which ones are the easier ones to get done, the faster ones, which ones do you know better as the client that it's not going to be a struggle, and which ones do you have resources that you can get to, and looking and negotiating with your vendor. A lot of it is vendor negotiation on your contracting.
Very good, very good. April, was this ever the kind of process or project you entertained doing in-house, or was that just not conceivable?
We have implemented both an on-prem model as well as a cloud-hosted model. You know, each has their own advantage or disadvantage. For clinical archiving, we chose to go with a cloud-hosted model, and you know that really does depend on your organization. You know, determining if that cloud-hosted versus the on-prem is really to your advantage.
Very good. Doug, how about you? Did you guys ever think you could do this in-house, or did you always know you were going to need a vendor to help?
Well, so with partners over the last 2 years, I worked in 2 very different environments. So at Mass General, they had the luxury of data repositories that they've been feeding with their clinical systems over the past 10, 20 years or so. And so in terms of kind of dissecting their archiving requirements, it was really kind of element by element. They already had an in-house solution for a lot of it. We just had to make sure that we were covered both from the HAM standpoint and other consumers of that data, research, or whoever it might be. But with Cooley Dickinson, we were in a much different environment where, you know, we didn't have the repositories. So we had kind of 3 standalone EHRs that we had to account for right off the bat, and looked to combine those into a single solution. We did consider in-house briefly. I think we had one rambunctious developer that wanted to create a viewer. And to this day, I'm sure he'll say that he could have done it, and I'm sure he could have. But in terms of, you know, coming up with something that would be delivered at our Epic Go Live, you know, in a ready state, and something that was scalable, and all those other things we've kind of discussed through this call, that you know, checking off all those boxes was a little more desirable than, you know, maybe just getting something in-house in place that could maybe meet a couple of those requirements.
Very good. All right, a couple of audience questions I want to get to before we're out of time. How much data did these provider organizations actually convert to the new EHR versus archiving? Doug? So
Partners was very strict about what we could bring over to Epic. So I think, as I said a little earlier, There were certain elements like immunizations and allergies and I think problems and a couple of others where we were able to bring that information over to Epic, but everything else, you know, needed to live in the archive. And so that was kind of our restriction.
April?
When we migrated to Epic, we did not migrate patient data. We migrated, you know, demographics to create that shell of the patient. At best, we may have pulled in 3 months of some important detail, such as allergies, et cetera. But in our experience, not just with Epic, but with other core clinicals across the organization, we do not take a path of data migration. And so when we consider archiving, we are pulling all data from that legacy system.
All right, very good. Another audience question, is it concerning to have all your data out on the cloud versus in your own data center? Who wants to tackle that?
Yes.
Go ahead. A little more color there, Doug?
You know, just to expand on that a little bit, certainly, you know, there's a concern there, obviously. And so, you know, in choosing a partner and a vendor, you know, to go on this journey with us, obviously we needed to make sure that they could meet all the standards in terms of security and data integrity that not only Cooley Dickinson had, but that Partners has in whole. And so there was a lot of scrutiny put forth there, but I think our vendor met the challenge.
April?
So when we considered cloud versus on-prem, there are certainly differences in reasons for making that selection, cost being one of them. But it really is hard to compare apples to apples when you're thinking about on-prem versus cloud-hosted. With an on-prem solution, you still have some of the same risk of data loss, security exposures, outages, et cetera. You also have to consider with an on-prem solution the cost it takes to maintain that infrastructure and the resources required to support that infrastructure. So it really made sense for CHI to go with a cloud-hosted model.
Okay, very good. Christy, I'm going to give you the final word. Any further comments you want to make? Final advice to our audience? We assume most of the people on the line today are either in the middle of this or planning to tackle a project. What's your best advice for them before we let you go?
Lessons learned, properly plan. Establish your goals and your metrics and make it happen. I think the lessons learned that all of us have mostly shared is some of the things we've called out today, right? Not knowing all the items. Do you really know how to get into your systems? Do you have the staffing, the resources? So I think it's all planning, and that starts with which systems are up on the table to even archive. Do you know your regulations in your state and your federal? Do you have buy-in from your entire organization of this is what we're going to do, this is when we're going to do it. So I'd say planning and if strategy planning and just having those initial conversations before you even start down the whole path is something folks are interested in. You know, with our experience in the legacy system retirement, even if it's strategy planning, it can be quite beneficial to understand the big picture before you get down in the weeds.
Excellent. Excellent. Well, that's about all we had time for today. When you close out your WebEx window, you're going to be taken to a post-event survey. If you could take a moment and answer that, we would appreciate it. For those of you with continuing education concerns in today's event, attending our webinars gets you 1 CEU towards the CHIME CHCIO program, so let CHIME know you were here. And if you've asked us to do so, we certainly will. If you need a certificate of attendance for another CEU program, you can use the final slide in this deck. You'll receive an email when our archive has been posted to our YouTube channel. If you'd like us to produce a webinar on the topic of your choice, you can contact Nancy Wilcox, and you can go to our website to view our upcoming schedule of events. So with that, I want to thank our panel very much, Doug Miller, April Morris, and Christy Erickson, and I want to thank Galen Healthcare Solutions for making today's event possible, and I want to thank you, our attendees, for coming to our events. So with that, everybody have a wonderful day. Thank you.